Everyone. This is the fourth of our CPCRN learning series. So we are the Canadian Primary Care Research Network. And today we're going to do a learning session on evolving practice-based research and learning networks into the learning health system through co-design with all partners. So a few words first about CPCRN. So the Canadian Primary Care Research Network vision is to create a sustainable pan-Canadian learning health system supported by patient-oriented, practice-based research that improves primary care. Our mission is to facilitate research to spread and scale innovations by building and growing local practice-based research and learning networks and developing a primary care information system. Today's session, we talk about practice-based research and learning networks, which are designed to bridge the gap between clinical practice, research and improvement by conducting studies that directly address real-world issues encountered in primary care. The growth and sustainability of practice-based research and learning networks is a perennial challenge. Generating research evidence and meaningful data that leads to improvement for primary care and patients could demonstrate value to health systems and enable spread and scale. Sharing solutions to enable practice-based research and learning networks to mature across a range of dimensions related to data systems, trial coordination, and quality improvement could create research that is relevant to primary care providers and system partners. By taking a learning health system approach to the PBRLNs, we can continually improve and ensure that each of us are working to our full potential. So today we want to identify essential components needed for the growth of a PBRLN. We want to describe a PBRLN maturity matrix model that defines core capabilities for a learning health system. And we would like to discuss the importance of building sustainable engagement practices. I am Sabrina Wong. I'm one of the co-chairs for the Canadian Primary Care Research Network, and I am coming to you today from Vancouver and would welcome you to put into the chat box where you are sitting today. And I'm in the unceded territory of the Squamish, Tsleil-Waututh, and Musqueam people. And today I am going to now turn it over to Dr. Ayat Salmon, who is the Operations Director for the Canadian Primary Care Sentinel Surveillance Network at Queen's University, and also the chair of the ISO 276 in biobanking and biotechnology. And she's going to introduce our speakers today. So over to you, Ayat.
Thank you very much, Sabrina, and thank you for the introduction. Thank you to everyone who's able to join us today. We have two great speakers lined up for us for a presentation. But before I start, I would first like to acknowledge the land that I'm actually giving the presentation from here. I'm from Queen's University in Kingston, Ontario, located on the traditional Anishinaabe and Haudenosaunee territory, and we're grateful to be able to live, learn, and play on these amazing lands. And as Sabrina mentioned, we really invite you to put in the chat box the land you are actually attending, from which you are attending the meeting today. Just a quick presentation of myself and also CPCSN. As Sabrina mentioned, I'm the Operations Director for CPCSN, the Canadian Primary Care Sentinel Surveillance Network. For those of you who don't know, we are an organization of close to 800 practices across the nation. 14 to 16 PBRNs representing 8 provinces. And we collect EMR primary care data from approximately now 2 million Canadian patients across the country. But today is not really focusing on CPCSN, but focusing more on the maturity models for PBRLNs. And to introduce the first speaker, Dr. O'Neill Bhattacharya is the Frigon Blow Chair in Family Medicine Research at Women's College Hospital and evaluation lead at the Center for Digital Health Evaluation housed at the Institute for Health System Solutions and Virtual Care. And he's also the associate professor in the Department of Family and Community Medicine at the University of Toronto. At the DFCM, which is Department of Family and Community Medicine in Toronto. He's also the virtual care lead of the Exploring Innovative Technologies in Family Medicine Collaborative. And he is also the national co-chair of the Primary Integrated Healthcare Innovation Network funded by CIHR. And he's also the clinical lead for the Ontario Network, Better Access to Care for Complex Needs. So it's up to you, O'Neill, to give us a great presentation on evolving practice-based research and learning networks.
All right, thank you. Thank you, Ayat. And I'm coming to you from Toronto, or to Toronto, the traditional home of the Wendat, Haudenosaunee, and the Mississaugas of the New Credit. So I'm going to talk a little bit about PBRLNs in general terms and how they fit into our network, and talk about an emerging framework that we are developing as a group. So, you know, we've heard many times over the years that health systems are in crisis, and the idea that systems are on the brink of collapse, harming healthcare workers and impeding patient care. So this, you know, was a problem before COVID, got worse during COVID, and the idea that there's urgent action required. I mean, in many ways, like, you know, this narrative of crisis obviously comes again and again, and has had multiple times over the years. But clearly, many of the problems we face now are either unique or much worse than they were previously. And so one of the reasons why, you know, we are getting together as a primary care community is to build a better system. So within primary care, some of our core challenges are an increasing number of people with chronic conditions. So the burden of disease is rising. And yet at the same time, we have unprecedented numbers, 6.5 million Canadians unattached to primary care. Access, you know, in international terms, is worse than many other peer countries, with 1 in 5 attached patients having difficulty accessing same or next day care. And obviously, it's probably worse statistics for people who are not attached. And inequitable access to quality care due to many factors related to the social determinants of health. So we have a system where many people have access to, or some people have access to a lot of care, and some people, a smaller number of people only have access to some care. So the idea that we need to expand that and give everybody access to something is sort of a principle that I think is driving primary care currently. One of the major challenges is obviously issues with workforce shortages and burnout. So it's not only the number of doctors who are currently in practice and other primary care providers and other types of professionals, but also early retirements, a large number of people who are older providers who are close to retirement, and then increasing rates of burnout. So on one hand, the shortages, we've got some shortages, and on the other hand, the proportion of people who have complex needs, multiple chronic conditions, and require, you know, managing primary care in ways that are really increasingly complex. Even the management of simple conditions like diabetes has increased in complexity over the years. And lastly, primary care is, you know, organized often in small clinics in a way that's kind of atomic, and some might argue subscale. And so it's challenging because we don't have a lot of infrastructure to evaluate, share, and scale innovations, particularly if we compare ourselves with the hospital sector. So primary care is run like a bunch of independent businesses across the country in ways that are very autonomous, which has been maybe historically easy to organize, but does not enable transformation. And in some ways, has led to a lack of engagement of patients, policymakers, clinicians, and researchers in the primary care space, because it's not set up in the way that hospitals are that facilitate engagement of all these individuals. So what are the solutions? So one is to, you know, build a large network that can explore and scale innovation across provinces, that can measure and iterate on various activities to ensure quality, that can, be a structure that enables meaningful stakeholder and patient engagement. We want to ensure continuous improvement at the practice level, recognizing that the capabilities across practices is extremely varied. We want to be able to coach clinicians, and we want to promote joy in work, and to recognize that the best way to combat burnout is to bring joy to the work and think about all the things that will make this job more rewarding for those of us who are currently in practice, as well as attract more people into primary care. So what is our network trying to do here? So first off, we're trying to build capacity, and this learning series is one of our key methods. So we want to increase capacity among researchers, clinicians, policymakers, community members, and Indigenous communities and members of other communities to engage in the idea of a learning health system and engage in a range of activities that relate to understanding practice, collecting data about practice, generating knowledge, and changing practice. So we want to build capacity, want to create governance, nurture a highly coordinated, decentralized networks. This is a federal activity in a sense that it is pan-Canadian. We have networks across the country, and we're trying to get them to work together in ways that facilitate growth. We want to engage and nurture sustained partnerships with diverse partners. You'll hear from Brenda in a moment. She represents, we've got patients, but a wide range of partners, including policymakers, clinicians, and others. We want to promote equity, diversity, and inclusion, create opportunities for Indigenous and equity-deserving people to become researchers in primary care, and create primary care services that suit the needs of those groups. We fund a wide range of research projects, 9 in total, and really the goal of those projects is to scale and spread successful patient-oriented research and innovation. So all of our projects are cross-jurisdictional, and they're spreading across multiple provinces as we proceed. And lastly, the goal of the network is knowledge translation and exchange, to generate and mobilize knowledge that can inform and transform practice. So if you think about it, this investment, so the CIHR strategy for patient-oriented research was an investment in network research. And the thesis is that if you give a large amount of funds to an organized network, you will generate more value than you would if you gave a small amount of funds to a large group. And so in primary care, historically, we're a diverse and dispersed group that is not particularly organized. And so as a research community, we want to build that. We want to build enable these functions so that primary care starts to look more like a system. One of the ways in which primary care can start to look like a system is through practice-based research and learning networks. And so the Canadian Primary Care Research Network is really investing heavily in this, both in supporting them directly, but also in understanding how they work and how they can grow. So here you can see we've got a total of 550 providers across the country, and around 2.3 million patients included in these networks. And you can see here the stats for all provinces. Many provinces have more than one network. Some provinces, like in Ontario, has 7 networks that have come together in one network called Poplar. And similarly in Quebec, there are 4 networks within the provinces, within each university, that has come together in Réseau 1 Québec. So it gives you a snapshot of the range of networks, and obviously their size will vary, according to the size of the population, but also, how long they've been around. So some of them have been around for more than a decade, whereas in Saskatchewan, Northwest Territories, and PEI, they're really just at the beginning. And so part of this exercise is to help them look at what are models, what are directions that they may take as they grow. We've really talked, we've introduced the idea of learning and learning health systems because, one of the reasons, when we when we started the Canadian Primary Care Research Network, the next iteration of this SPORE network was the idea of shifting from practice-based research networks to practice-based learning networks, research and learning networks. So trying to put that learning function in. And so this is a diagram from Rob Reed and some of the folks at the Trillium Health Partners, I think some of whom are on this call, and really looking at the history of research was something that was distinct from care delivery. It's funded separately, different initiative, different operations, different people operating on a different set of incentives, and often in the same organizations. I'm, a clinician in a tertiary hospital, academic teaching hospital on the research side of the house. And though I provide primary care in the, within this hospital, all of my activities as a researcher are distinct from my activities as a clinician. One of the goals here is to start to use knowledge translation and exchange to promote more exchange between the research community and the care delivery community. And eventually, by embedding applied research and evidence supports into an organization, you start to come together as a learning health system where these Venn diagrams start to see overlap. Trillium Health Partners has been a leader in this area. My institution has made this an important strategic goal. And this is a job that many, many organizations are trying to move towards, but it's inherently challenging. It's inherently challenging not only because the required skill sets are different, but also the incentives are different. And so it's a new way of working. Now, if we think about how do we evolve practice-based research and learning networks into learning health systems, we have two challenges. One is the challenge of primary care and its separation from systems, but also the challenge sort of, what is the PBRLN actually focused on? So let me give you 3 examples of activities that a PBRLN might be focused on. A PBRLN that was focused on quality improvement, or if probably an improvement idea comes forward, you could imagine the director of a clinic saying to a PBRLN lead, we have problems with stockouts. There's always medications that are stocked out, and then we need to figure out every patient in our clinic who is on, ranitidine, and we need to change them to famotidine or some other drug. And so we need to generate a list of patients who are on this drug that's no longer in stock, and then reach out to them and then send a whole new different set of prescriptions. So that's a quality issue, but it's a pretty operational issue. And so in a QI-focused PBRLN, operational leads would bring a question like that maybe no researcher particularly cares about, but there's a data system to do it, and they would enable that function because it's, maybe because the clinic invests in these, maintaining these systems, but that would be a sort of QI-focused project. Then you could have a research-focused project, for instance, an adaptive platform trial on new treatments for COVID. And that's something that, workaday clinicians might have a general interest in, but they're not going to lead a project on that. They're not going to generate that question. That's going to come from researchers. And researchers, like our colleague Andrew Pinto, might get $10 million to do this, do a study to build a platform like this and roll it out across multiple regions and recruit sites to roll out a protocol that has been developed centrally in collaboration with those sites. But really, the goal is research and the funding is research driven, and it's kind of, that's the activity, the core of the project. On the learning health system side, I'll give you an extreme example, but let's imagine that in a province, and this is actually a real world example, but in the province of Ontario, the Ministry of Health is rolling out billing codes for patient to provider secure messaging. And their question is, how do these billing codes work? What kind of behaviors do they, incentivize? And how good are these billing codes at doing what we hope they do? And so then they might say, well, in your PBRLN, can you give us 6 or 7 clinics that sign up for this pilot with these new billing codes? And then, research leads and team, please go into those clinics, mine the EMR data to figure out how billable and non-billable secure messages are used. What is the content of the message? How does it fit into their workflows? How are they billing for this? Do interviews to understand whether people like it or don't, and what the value is. And so that's kind of researchy, but the question comes from the ministry. Let's say they're paying for it. There's a 6-month timeline, and it's aligned with a policy decision around whether we renew these billing codes or we change them. All right, so those are 3 examples of QI-focused project, research-focused project, or a system-focused project. Now, that's a bit, the ministry, answering the ministry's questions is one way in which primary care starts to engage with systems. But so those are 3 things, 3 types of projects, all of which exist, and then there are examples of things one might do in a PBRLN. Now, if we think of this broader idea of maturity of PBRLNs, we think about these different stages. So this is a kind of high-level version that Sabrina has generated. We're looking at a range of the literature with input from many of us, but I'll give her credit for generating the first version of this. And so we think of 4 stages in the maturity of a PBRLN. There's the formative stage, small group of primary care practices, patients and researchers getting together to say, okay, let's organize our activities so that we can improve primary care in our region. The next phase will be growth and expansion. You're expanding membership beyond an initial core. You're establishing basic research processes and governance structures. You have increased capacity and engagement in a wider range of projects. And you're facilitating each project so you're not starting from scratch, but there are a set of standard processes. The next one would be knowledge translation, mobilization, and innovation. So now this PBRLN is generating research and findings and QI that change mobilize knowledge in the region. They are a leader in primary care research within their province or region, and they are driving innovation in clinical practice and research methods because they test new methods and new practices that are then taken up elsewhere. And lastly, you could have sustainability through embedded applied research and evidence. So here you have long-term sustainability, long-term funding, and impact on primary care and research. You provide system-level leadership, so you are being approached by health system leaders to answer questions, and you can link local data to provincial administrative data. So those are kind of 5 stages you might move through. Now there's a bunch of components within this. And so these are kind of the network infrastructure components. The first might be governance and organizational leadership. So do you have shared leadership? Are you including researchers, clinicians, maybe administrators, patients, or policymakers? What kind of governance structures do you have? Funding, how many staff are hired? What is the scientific expertise of affiliated scientists and staff? What is the number of projects? What is the dollar amount? Data and technology. Do you have access to EMR data? Do you link to administrative data within your province? Are you submitting data back to clinicians in frontline practice? Are you submitting data to national networks like CIPSN? And lastly, to what extent are you building a learning network? Do you engage patients and community partners? To what extent is the health workforce engaged in the activities of the PBRLN? And to what extent are Indigenous and equity-deserving groups engaged? So we built a template around this with definitions that are still a work in progress. And this was sent to all the PBRLNs across the country. And thanks to all of you who filled it out. We got them to answer a bunch of questions. And I think we're still working on some of the definitions. And we're trying to layer on both these components with these stages of maturity. And most of the data, I'll be honest, landed on Friday. So we are still refining, analyzing it, and we'll come back to you with something more refined. But I'll give you a case example of something that we think of as a bit of an exemplar. So this is the Alliance of Healthier Communities, Practice-Based Research Network, also called EPIC. It's within Ontario. In terms of governance and organizational leadership, it groups 120 clinics within this alliance that includes nurse practitioner-led clinics, community health centers, and a wide range of community-led clinics. It has a leadership team that includes people that leads for improvement, strategy, and information management. It has a large number of staff, including a director of research and policy, research and evaluation leads, a policy analyst, knowledge translation specialist, and quality improvement and performance leads. It has stable funding through this quite large organization. It has a dedicated budget to support learning health systems activities and a special project funding, as well as a research reserve fund. In terms of expertise, it has a team with expertise in clinical informatics, public health, and quality improvement that leads a wide range of projects and participates in projects from elsewhere. They have a data warehouse, they provide data support, they generate a set of common metrics and patient experience measures, they send practice reports routinely back to clinics, and they're able to link data with administrative databases in Ontario. In terms of patient community partner engagement, they have a patient advisory board who are involved in the governance, research direction, and co-design of projects. In terms of health workforce engagement, the projects are guided by staff advisory groups, which includes administrative staff, clinicians, and team members. They free up staff time to participate in research and other learning activities. So, health workforce engagement is very strong. This is clearly a focus of the entire organization. And they built out a learning network where they host communities of practice around things like community vaccination. They did a large one around social prescribing. And these are also open to non-EPIC members, so members outside of their network. And this is quite a remarkable statistic. 50% of sites have participated over the last 3 learning collaboratives. So the level of engagement across this very large network is remarkable. So, I highlight this one because, it's an example for us of a mature network. But when we think about the broader, the overall metrics, and I'll just take a second to move on to that. When we think of maturity models, it's not a scorecard. I want you to think of this as a way to inform strategic decisions. So there are issues, if we think of these broad dimensions, leadership, staff, funding, expertise, data, patient engagement, workforce engagement, and the learning network. And there's 2 others actually that I didn't include here, but engagement of Indigenous communities and equities of deserving communities. You can first of all think about where you're at as a network, but also where do you want to go? So this is not a one-size-fits-all. This is not a linear process. One of the core questions early on in a PBRLN is, are you going to put your energy into building a data system, or are you going to put your energy into coordinating research studies? And there's a wide range of things. So just as when we looked across the responses to groups, some networks only have a handful of staff and they're just starting. Some of them have unstable funding. Some of them get core funding from their Department of Family Medicine or some other group. The range of expertise varies widely. The data infrastructure is probably one of the ones where we see the biggest variation, and obviously networks that are just getting off the ground will not have EMR databases that are all built in. The ability to link data varies quite a bit, but the contribution to SIPSN data, and I can talk about this more. That is there are more networks that do that. On the patient engagement side, again, widely varying levels of ad hoc engagement in individual projects versus patients who sit on, advisory committees. And Brenda can elaborate a little bit on what she's seen thus far. The workforce engagement, this is probably the one where we see the biggest spread. What I described to you in the Alliance of Healthy Other Communities is off the charts. I don't think other networks have achieved that level of penetration. When we say, half of the people have participated in one of the learning collaboratives, that's, remarkable. But I would say often the activities of workforce engagement versus research are sometimes in tension. And I'll talk about that in a second, but just to say that's another one that varies quite a bit. And then the learning network, the extent to which activities are concentrated within an individual PBRN, whether it's, engages more at a provincial level or a pan-Canadian level, again, varies quite a bit. When we think about maturity models, the unit of analysis is also an important thing. Is it really just about a given network, or is it about the network of networks at the provincial level, like Poplar in Ontario or Réseau in Quebec, or is it about the national activity? So, those are all things that are sort of open for consideration, but I think at this stage, we're thinking about the individual network. And lastly, this is going to come down to strategic decisions about what matters for you as a network. And in some ways, you'll think about where is the energy, where is the money, and where does your leadership want to go? Quality improvement, I think, is obviously a key way to engage frontline clinicians whose interest in research will be modest often. But getting large amounts of funds for quality improvement is hard. but it may drive engagement. Research is, it's easier to get research funding. Clinicians or researchers can drive research projects through PBRLNs, particularly observational research, but also trial research by paying per patient, by bringing their staff in. And so it's something that it is probably tried and true, and one of the most developed ways of growing the network. And the last one, learning health systems, really engaging with policymakers, is, I think, an emerging opportunity. In Ontario, the provincial government has given $5 million to the popular primary care PBRLN, probably because they see value somewhere. They want to be able to use that data in some ways. And interestingly, in the history of PBRLNs, they were separate from ministries because primary care providers don't want to give that data to the ministry. And so that, distrust probably still exists in some places. And so PBRLNs that mediate between the ministry and primary care practices is probably an important role. But as we move towards learning health systems, I do think engaging with policymakers and helping use these living laboratories to drive system change is going to be an important function. All right. I think I'll pause here for questions. You're our moderator. Do you want to we can take some questions now and then we'll move on. What do you think?
O'Neill, I think we'll give Brenda the second presentation first. I think it'll drive more discussions once we hear from a bit more of the patient engagement perspective. One of the fuels you actually presented in the maturity model. So I would rather have that, then we can open up the discussions for everyone. So for our second speaker, Brenda, so our second speaker, Brenda Andreas, is going to talk to us more of the patient engagements, which is one of the fuels that actually O'Neill presented in the maturity matrix. But before she starts, I'd love to present her. So Brenda is a patient partner, and a research collaborator. And she's also the co-chair of the CPCRN Patient Council and a community member of the CIHR IAB HSPR. She is going to present to you more of the aspects of patient engagement on different levels, more on relationship, accountability, belonging, and participation, and how that engagement is important in the maturity model that O'Neill presented. So it's all to you, Brenda.
Thank you, Ayat, and thank you, O'Neill. I love listening to you because you always put things in a language, plain language that I can understand, and that's really important. So I had a prepared speech here, and I could go into it, but I don't want to. Instead, I want to reflect upon and build upon what O'Neill has said to us today. And I took away 3 key messages. 1, the importance of the data to health system transformation, and how we do that is through transparency and accountability. Secondly, the relationship of data to the people we provide care to, and their knowledge and understanding of what that looks like for them and how it can support their shared decision-making as they move through the healthcare system. The other piece is really around belonging. Belonging in a sense of where you live determines how you experience care, but also how care is provided to you. And you started out, O'Neill, by talking a little bit about how primary care, which is the entry point for many of us into the healthcare system, the importance of belonging and a sense of community from the point of where we live. And knowing that our healthcare system is there to meet our needs, but also to provide us with what we need. And having said that, it goes back to, again, of how data is the currency we use to support health system transformation through evidence-based best practices and science implementation. What we don't always understand about that is patients and family and communities really don't know what goes on behind a closed door to make sure that their outcome and that their experience of care is going to be what they expect it to be, but also what the provider expects to give to the patient in terms of their role in providing them with a safe journey through the care system. And most of what I say, it comes from, as Ayat has said, my experience of being in the healthcare system, but also as a research collaborator, I understand what is the difference between quality improvement and research. The biggest piece in all of this is how do we bring together researchers, clinicians, policymakers, health systems themselves to enable and support what we all want is better patient experiences, better provider experiences, and better outcomes for the system in terms of cost efficiency and effectiveness. Gee, I'm getting nervous today. And how do we move toward a collaborative decision-making approach where health literacy and data literacy support the patient and the community in their decision-making? Willingness to engage. So what does a maturity matrix really look like from the patient and community perspective? First of all, there has to be a willingness on the part of the system and the researcher clinician to really look at, are we willing to engage with our community? Does the PBRLN LHS community want to engage with the broader community? What is collaboration with the people most effective, and why is it important? It is about reciprocity through a meaningful partnership with outputs that serve the community members, which leads to the question of what are the barriers and facilitators to the partnership? And this is where every health system, every PBRN is different, because whatever it is in terms of your resources, that will determine how you would approach the elements of what is foundational to patient engagement. Secondly, then you need to think about resources. Are there resources to support the micro, the meso, the macro level? Has there been a co-design of structures and mechanisms needed to create a culture shift? And isn't that why we're here today? Isn't this all about a shift in culture to create that sense of community belonging so that we can all feel, whether we're that policymaker, that researcher, that clinician, or that community member, or that patient, what do we all really want? We want to belong. We want to know that we're going to receive safe and appropriate care. And sometimes I think we don't take the time to really look at what are our values? What are our principles and values around how the community, and how is this embedded in our community? So therefore, then our community is a PBRN or a learning health system. Do we take enough time to really think about what drives our decision making? What are the ethics behind what we do and who it's important to? So back to the data as currency and how engagement is being evaluated. Again, I go right back to the very beginning. Data is currency to the healthcare system, but so are the people we serve, the people who provide care, the people who are members of our community. And how do we evaluate their experience? And I think there's no one simple answer, because I wrote it down like this. A culture of belonging builds relationships. Relationships enable us to work together to evolve what are our values, and how then would we implement, and how would we support those values to do the work that we do. All of this, I'm saying to you, one size does not fit all. Every community is different. Every PBLN is different, and every practice is different. I'll stop there.
Thank you very much, Brenda. I think there's going to be a number of questions in the audience. I hope so. I mean, this is opening up, I think, a good conversation, and I would say getting some engagement from all of you who are present today would be great to hear some of the perspectives. And if you have any questions also regarding the maturity model that O'Neill presented, or even comments, I think that will open up a lot of the conversation today. So before I put in my questions. First, maybe we can go to the audience to see if anyone has any questions, comment, to either Brenda, O'Neill, or maybe, you know, a question that you want to open to the audience and open up some conversation in there and see where we could start. So I'm opening it up to the audience. Does anybody have any questions? If you have any questions, you can just raise your hand and we'll let you ask your question. Yes, Vivian, go ahead.
Well, I want to better understand, so thank you both for your presentations. I'm hearing it, O'Neill, that in fact the model is top down, and as you probably know, the models for best policy are both top down and bottom up. So I'm curious to know how you see the bottom up parameter of this particular model unfolding.
Yeah, it's interesting you say that, Viv. Is it, I guess, I try not to give a direction. I think ultimately networks are going to choose, you know, who drives this. And maybe it's a coalition of people with a range of interests that drive it forward. I think historically PBRLNs were set up by people who are interested in research, and they probably drove it initially. And now it's, you know, a wider tent, and you're trying to get clinicians in who are interested in quality improvement. We talked a little bit, you know, we talked about patients as a community and policymakers. Yeah, I don't have a perspective. I think like a top down, like, you know, ministries can't drive this for sure, because there's not enough trust, right? And Brenda talked a lot about belonging and being part of it. I think, in fact, for primary care providers, they don't belong to the research enterprise, and that's why their engagement is fairly modest. I had a question for you, Viv, because when I looked across all the models, all the data we got, you know, engagement of Indigenous communities was pretty marginal. Most groups said, we're trying, we're starting, and it was on the, you know, not as mature side, but I feel like you've got a network that's, you know, starting, but where you've put a lot of energy into that. And I'm just curious, why don't you give us your thoughts on something that is, you know, maybe more bottom up?
Well, thank you for the question. I guess the most interesting part of that question for me is it's built on relationships, and relationships that have been achieved over time. And so we had the same positive outcome with the Paris project as well, because it's built on relationships over time. And so my experience in developing research in Indigenous communities is they actually drive it, though. It's not the researcher who drives it. And so when you're looking at it from that top-down framework of taking data and actually using it for other things, that just won't fly. And so then it's about how do we actually engage them in ways that are meaningful to them, to help them see that, in fact, answering questions will provide a better health and wellness outcome for their community. And so having worked in several Indigenous communities, both here and in South India, the community actually knows what they need. They don't necessarily know how to answer the questions. And that's what we bring together. And so together we actually are able to find some very unique outcomes and change practice, both at that level and at the provincial level. So I don't have any answers either. I just know it takes time, values, and relationships.
So Viv, if I can ask you to, you know, take the sort of measures that we've developed so far and build that out, because I think that's a weakness of the model thus far. And engagement is very difficult, and it's actually a big limitation of PBRLNs, probably for many of the reasons you've just described.
Well, it's interesting you ask me that question, because I actually had a back and forth with Sabrina about this, because we've at the first stage, we're probably not going to frame Simpson in the same way that has been framed across the country. We're much more likely to have a PBRLN, because it's really about engagement. And in that, building it together, we're actually going to engage the people in deciding what the questions are, how best to answer those questions, what that might look like. And the people for us are not just The researchers, they're the actual people in those particular clinical settings, primary care settings, whether they be nurse practitioners or family physicians and patients. And so you probably know that we're developing a community advisory committee consisting of patients in each of our sites. And so it's a broader endeavor, but it's really about answering the questions of the people in ways that they can actually see a change. So we come from the first level and we go to the third level, where in fact we're already doing knowledge translation because that's part of it. And then we're actually moving on to thinking about policy and how that might evolve within those communities. So I don't know if that helps or not, but we're not there yet, but we're moving forward.
Thanks, Vivian. Joan?
Yeah, I really like what's being said and the language that's being used about how we're all different. I work in a very small site. I'm a clinician and I'm a researcher. I'm working on communities about age-friendly planning. And we also have a small research collective, a regional research collective. And I think the thing is that is working about what we're doing is that it is not top down. I never thought of it as an Indigenous way of speaking, but I think it is. It's that talking circle thing. So my meetings are not somebody at the top talking it the whole time and then a few minutes discussion at the end. Our meetings are round tables. At my research collective, it's everybody's favorite meeting, and the community meetings I have. How do you engage? You come back often, feed them good food, and listen to what they say. And then you keep going back and back. It is very circular. I find it much easier to do in my small rural communities. I don't understand how to translate it up into these higher levels, but I can be the piece that starts at the bottom. And I think there's lots of great minds here who know how to do big pieces at the top. So if we all work together, we'll get there, but it is very relational. And the Pan-Canadian Patient Council that Brenda chairs and that Viv is involved with is another of my favorite meetings because it's very roundtable knowledge sharing. That's where it starts. Thank you.
Thank you very much, Joan. Alan, and then I'll go to the question that's in the chat box.
Thanks for the presentations, which I really enjoyed. Lots of good stuff there. I, however, want to very much compliment Joan on what she described as the way we should all be working. That's fantastic work to hear about. And you've highlighted the challenge, though, in how do we, and this relates to what Viv said as well. How do we change the structure that we currently have, the old Simpson way of doing things, the old top-down way of doing things that are currently in existence? And if we really want to learn from each other, we need a different model, which is the kind of model that Joan has described. Well, that's very difficult to do in a large network of multiple providers. And so I do think that needs to be built into the maturity model in terms of moving away from the traditional structure and talking about learning from each other. And that's the way I would frame it, because if it's a learning health system, then a research and learning system, the learning component is the weakest, I think, at the moment. We've started off with a bunch of researchers. Most of us are involved in education as well, but we need to have a different way of working together if we're going to be learning from the actual clinical experience and from our patients, which is what learning health systems, I think, aspire to do. So I'm really excited about having a model and having a maturity. And I just want to say I really appreciated, O'Neill, your comment that this is not a scorecard and you get a point and you move on. It's about identifying the areas for growth. And that to me is really what that maturity model is all about. So thank you for great work.
Yeah, thanks for those comments, Alan. And I think, I'm thinking about Vivian's comment about engagement. One of the PBRNs that struck me as mature in its ways is Jack Westfall's PBRLN in Colorado. And that, they're not about volume. Like if you look at their metrics, I'm sure they're not driving a ton of research dollars and they don't get a ton of high impact publications, but the degree of engagement in those studies is remarkable, and retention and so forth. So I really enjoy the comments you've just made. I think we'll go back to the framework and really build out this idea of engagement as a core element. And, I guess, Alan, you'll relate to this. Like, we come from a culture of like, dollars and grants, how many dollars, how many grants, what's the size of your operation, and what's the output. And it's, that's very different. We don't have to try and be like specialists. This doesn't have to look like the Critical Care Research Network. It can have a different flavor. And I, thank you for Vivian and Joan for just saying, like, let's set out a different aspiration and like lay these out as options that people can choose as they move forward.
It's a paradigm shift that we propose, or that's being proposed, and I think one that won't be popular with everybody, particularly those people who are accountable to academic institutions, and there are all kinds of issues around that, and we know we've been talking about that for years as primary care researchers. But I do think it's important. I also wonder about how we're reaching the 6-point-something millions of unattached people in this model.
Brenda, do you have anything to add to this?
I do. I really think that really bottom up is really the way that we need to go. But more importantly, we also have to consider the new approach that's been in existence for the last 10 years within the healthcare system, which is people-centered care, and it has 4 pillars: respect, information sharing, participation, and collaboration. And everyone that's just spoken has really described that wall that comes about the requirements of each of the work that you do to the regulatory body or the institution that you are a part of. And really what it really all boils down to, and Jen Rayner, this would answer your question as well about what that would look like. One of the most exciting things is when you have a researcher or a clinician who is willing and able to be present with you in the moment as a patient or as a community member, and to listen, to hear, and to understand. And until we can make time or space that creates those structures and mechanisms so that all the people involved have that opportunity to take the time to be in reciprocity with the people that we serve, and with our colleagues that are working with us in our system or in our institution, where we can then say to each other, what matters to you? And listen.
Thank you very much, Brenda. And I think there's kind of a comment also in the chat box that kind of brings that conversation also together. Maybe the word maturity model may seem too linear. Maybe calling in PBRLN scorecard or readiness tool. What does everybody think of calling it something like that? Since this is kind of the discussion that's been going around. Maybe we can start with O'Neill. What do you think, Brenda?
Yeah, so I've done some work in maturity models in a different area, in like digital health and at the provincial level, and nobody liked it because they were going to be, it created a type of comparison that wasn't necessarily interesting for people. I do think that a lot of this comes down to strategic choices. And maybe one approach is to create archetypes, and it's like you have this style of network and that style of network, and they have these features. So I think there's something there, and that maturity model maybe will be hard. Like, people won't love to put themselves, on a scale where they're compared to others. Anyway, well, we can think about what makes it palatable, but I think the idea that there are archetypes and general strategies, I think, is helpful, because these are legitimate alternate choices that people make in the, as they grow a network.
Brenda?
I really think it's important, O'Neill, when you talk about strategy, but then you get down to the hard piece, which is the operationalizing. And without the willingness and the resources to buy into that. You can't really measure or evaluate. You know, in simple Indigenous language, you know, really we talk about being in right relationship. And I think there is so much to be learned from that. And we shouldn't call this anything more than how do we get to right relationship? Just saying it.
Alan, did you want to say something? You had your microphone.
I did. I actually like maturity model. I think it's better than scorecard, and I think it has other nuances. That maturity does not mean knowing all the answers. Maturity means understanding the context and so many broader things. And that's why I actually like maturity model. I think it's a change from giving everything a scorecard. So that's we probably will never all be satisfied with a title, but I wanted to bring that forward.
Thanks, Alan. Jennifer?
Hi, everyone. It's been a really interesting conversation. I was one of the worker bees on helping these stories get told within the maturity matrix framework, as I think all of you been tapped in one way or the other. So I think just a few things, and you might agree with this, with the comment that CIPSN membership and CIPSN operations represents the top down. I just don't, and I don't agree with that. I think the heart of the CIPSN community came from individual local networks that, you know, formed from those very small bases and collaborated with others and across jurisdictions to become the CIPSN network that is today. And is, you know, forms a really important primary care data backbone. Other jurisdictions are trying to form similar data backbones in collection with the culture of inquiry, patient engagement, continuous learning. So I think we're kind of on the right track as we are right now. Very much need improvements with patient and community engagement, though. And so my question, Brenda, it's me, Jen Lawson, not Jen Rayner, was to, you know, really start thinking about the nuance of what those pieces are and how do we really concentrate on building those up within our networks. But yeah, I think the stories are coming in. We all need to percolate on those some more, and we're going to have lots more opportunity for communication and discussion on this. So thanks everyone for your participation today.
And I just want to give a shout out to Jen, because you did this. You drove all the work. You organized all the thing into meaningful categories. And thank you for that, Jen. And we're now going to take all the feedback we got, not only in this session, but from each of you, to reorganize the matrix and bring that back to you in another session.
Brenda, did you want to add the last few words?
Thank you. I just really have to say that our healthcare system is based on humanity. The people we serve, the people that live and grow and play in our communities. And healthcare is really, really all about how evidence-based best practices can improve what we do and better outcomes. But we also are starting to spend a lot more of our energy and thinking about what is the patient experience, what is the provider experience, and how do we get those on the same page so that the stories that our patients tell, the stressors that our providers experience, the losses our communities feel when they no longer have access to the care that they need. So there's so much that we need to do, but we don't have to beat ourselves up. We just have to get there together.
Thank you very much, Brenda. And thank you, O'Neill. Thank you, everyone, for this amazing session. This was very, very interesting discussion, and definitely will bring Sabrina and all her team, and so Jen and O'Neill, back to the drawing board and reorganizing all of this. But thanks again. Thank you, everyone. And please continue following the CPCRN newsletter for the next upcoming learning series. Thank you, everyone. Have a nice day. Bye-bye.
Hi, everyone.